Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be helpful for our medical practices. In this episode, we talk with Professor Thomas Joblin on uterine and cervical cancer. Before starting though, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, uterine cancer is the fifth most common cancer in females and the most common cancer of the female genital tract in Australia, with about 3,300 cases annually and 660 deaths. The major prevalence is in women between 50 and 70 years, and the quoted major risk factors include early onset menarche and late menopause, obesity, nulliparity, unopposed estrogen treatments, polycystic ovaries with prolonged anovulation, extended use of tamoxifen for breast cancer, and Lynch syndrome, which confers a 30% lifetime incidence. Presenting with abnormal PV bleeding or prolonged post-menopausal bleeding, other presentations may include dyspareunia, pelvic pressure, weight loss, anemia, and in later stages, possibly pelvic pain. Whilst a pap smear will frequently be negative, pelvic imaging revealing a suspicious endometrium and subsequently hysteroscopy and biopsy guide the diagnosis. And patients with more than 50% myometrial invasion have a 6 to 7-fold higher prevalence of pelvic lymph node metastases in advanced surgical stage compared with women with less than 50% invasion. But with current management, the 5-year survival has improved over the past 40 years to 83%. Well, in contrast to endometrial cancer, which has seen an increasing incidence since 1982 of about 0.9% per year, cervical cancer prevalence has reduced from 14 per 100,000 in 1982 to 7 per 100,000 in 2017, influenced by the introduction of the HPV vaccine Gardasil in 2007. Gardasil 9 is the HPV vaccine used in Australia's national HPV vaccination program today, providing 100% protection against HPV strains 6, 11, 16, 18, 31, 33, 45, 52 and 58, which are known to cause genital warts and cervical and other HPV-related cancers. Types 16 and 18 cause most of the HPV-related cancers. The vaccine is recommended for all children aged 12 to 13 and is free for all Australians aged 12 to 25 years. The vaccine is estimated to prevent up to 90% of cervical cancers and 96% of anal cancers. Well, I was fortunate in this podcast to have a conversation with Professor Thomas Joblin regarding the risks and management of endometrial and cervical cancer. Tom is a gynecological oncologist, ex-AFL footballer and medical researcher with a very respected reputation in Melbourne and internationally. He has extensive experience with minimally invasive surgery, including robotic surgery for gynecological cancer. His main research area is ovarian cancer, for which he received an Order of Australia Medal in 2017. He's currently Head of Gynecological Health and VMO at Peter MacCallum Hospital. So please welcome Professor Joblin to the podcast. Professor Thomas Joblin, it's a great privilege for me to have you here on Everyday Medicine. You've been a very special kind of referrer for us for a long, long time and a great backstop to so many doctors in Melbourne for difficult gynecological problems. And it's a real privilege for me to be talking to you about carcinoma with endometrium and also the cervix today on Everyday Medicine. Before we start, Tom, can I ask you just a little bit about your journey? How have you entered this field, which is a complicated field of medicine?
Yeah. So gynecological oncology became a subspecialty in Australia in about I guess maybe the early 1980s or late 70s. It then became a recognised subspecialty in around about 1986. I completed my primary obstetrics and gynaecology training at the old Queen Vic Hospital in Lonsdale Street in the middle 80s, and then went to England for quite a few years and did general surgery, and then did my subspecialty training in gynecological oncology at the Royal Marsden and St Bartholomew's in London, and I did my doctoral thesis on ovarian cancer research at the Imperial Cancer Research Fund, and then came back to Australia in 1990 and joined the unit at Monash in 1991 and have been here ever since. So gynecological oncology has become a very sort of focused area of obstetrics and gynecology, and there are now about 70-odd what we call CGOs, or Certified Gynecological Oncologists in Australia, and we have 4 at Monash Health, and I'd like to think we've got a very good unit at Monash, and I'm sitting in the outpatients as we speak.
Yes.
And so today, our main area of research, in fact, is in ovarian cancer, both in biomarkers and screening and triage, but also we've developed a new treatment which we're putting through animal model lab experiments at the moment. But today we're going to be talking about endometrial cancer, which is probably the biggest problem that we have now in gynecological oncology. It's quite interesting, and if you're happy for me to keep talking.
Yeah, please do. Yes, it's more common than I realised, and I had a personal interest in this because my stepmother actually, unfortunately, did die from it, and it was detected very late. So it's sort of quite a personal sort of story for me, and so I was very interested to talk with you about it. But yes, please continue.
So the incidence of endometrial cancer, it's said to be 1 in 70, but it's going up all the time. And just some interesting numbers which have stuck in my brain for a long time. In 1982, the population of Australia was about 14.4 million, and we had 943 new cases of endometrial cancer in the whole country. In 2018, the population of Australia had gone up to 24.8 million, and we had 2,963 new cases of endometrial cancer. So our population had gone up by 2/3, but we'd trebled the number of endometrial cancer. And the single biggest reason is because of morbid obesity. And as you well know better than I do, Luke, morbid obesity increases the risk of at least 10 different cancers, including bowel cancer and breast, renal, esophageal, for reasons I'm not sure about, but certainly endometrial cancer. And it's very much along the lines of, if your body mass index is greater than 30, we know you now have a 10-fold increased risk of endometrial cancer. And it's probably to do with the conversion from cholesterol to estrogens through the aromatase enzyme system in fatty tissue. So the fatter you are, the more you make, and it's just phenomenal. So with patients that have got BMI of 50 or 60, their risk of endometrial cancer is stratospheric. And the interesting data is that they now say that by the year 2030, with our current trends, there'll be 500,000 extra cancers per year in the United States purely because of morbid obesity. So it is a serious problem. So if we're talking about risk factors, that is the biggest issue. In the old days, when people started hormone replacement therapy, or menopausal hormone therapy, as they call it now, people were unfortunately sometimes subjected to an increased risk because of unopposed estrogen. So their GPs might prescribe estrogen only, and we knew that caused a 10-fold increased risk. And it's probably, as I said, the same with morbid obesity. Now, obviously, medical practitioners are a lot more aware of these problems now, so hardly anyone would ever be prescribed unopposed estrogen. They're obviously given progestogens as well, which does protect their endometrium. The risk factors that you alluded to before, Luke, when we started in terms of Lynch syndrome, probably only contributes to a very small, less than 10% of endometrial cancer, probably only 3%, but obviously the 4 mismatch repair gene mutations we now are fully aware of. And so anyone who has an operation for endometrial cancer now gets obviously automatic staining for loss of staining for the mismatch repair gene-related proteins, and that's been a very positive outcome. In terms of the subtypes of endometrial cancer, there are, broadly speaking, 2 subtypes. There's type 1, which is, generally speaking, grade 1 and grade 2 endometrial cancer. And most endometrial cancer falls into that. So about 90% will be type 1. And then there's type 2, which is much more high-risk cancers, and that involves high-grade or grade 3 endometrioid adenocarcinoma, but more importantly, high-grade serous, clear cell, carcinosarcoma, and dedifferentiated carcinomas. They have a much worse prognosis and are a bit harder to treat, at least harder to manage in terms of outcomes. The overall treatment these days, 90% of people would be treated with minimally invasive surgery, either laparoscopic surgery or robotic surgery. Only about 10% of patients will have open surgery these days, which has been a major shift in the surgical management. preoperative investigations pretty much are anyone with abnormal bleeding will get a hysteroscopy D&C, and that'll be sent off obviously for histology. 80% of endometrial cancer occurs in post-menopausal women, but 20% obviously in premenopausal. So those patients are a little harder to identify in terms of risk factors because, of course, women in their 40s who have heavy periods, most people will just say, oh, you've just got perimenopausal menorrhagia. Oh, well, you'll be okay. But it is very important to be mindful of those very high-risk groups that we've just talked about. So morbidly obese women, not on hormones, not on the pill or anything like that, who are having extremely heavy periods should, of course, the alarm bells should be raised. But then some slim patients without an obvious family history are found to have endometrial cancer. So we need to be mindful of investigating appropriately abnormal bleeding in anybody. Obviously, a postmenopausal woman who's not on hormone replacement therapy and who gets postmenopausal bleeding at the age of 65, she has to be regarded as having endometrial cancer until proven otherwise. The standard investigations, of course, preoperatively for these patients who've got abnormal bleeding is always going to be a pelvic ultrasound, and we would be keen that they get a pretty high or tertiary level ultrasound where possible with a gynecological ultrasound expert. Obviously,
what are you looking for on that ultrasound?
So you're looking for a thickened endometrium, and if you're postmenopausal and you've got an endometrium, theoretically, and you're not on hormones, if your endometrial thickness is more than 4 millimetres, that's regarded as abnormal. If you're on hormone therapy, that's a little more tricky because, of course, you can get relatively thickened endometrium with hormone replacement. Premenopausal women, irregular or polyps, irregular endometrium or polyps are going to raise some concerns, although more often than not, polyps are a bit like colonic polyps. They're more often benign than malignant. But obviously, the default is always going to be hysteroscopy D&C.
Yes.
And obviously that will give you an answer.
So red flag, and those patients should be referred to gynecologists quite
probably. Yes. Absolutely.
Can I ask a little bit about, are you concerned about nulliparity? It used to be, that was one of the risk factors that was talked about early menarche, nulliparity. Yes. Are they very minor things? We're focusing on the estrogen component here, the obesity and unopposed estrogens. But are those other factors?
So nulliparity has been talked about, and it's not as easily identifiable as a risk factor these days, and we probably don't pay much attention to it. It's a little bit like ovarian cancer in terms of people have often said, nulliparity, it might increase your risk of ovarian cancer, and the concept was always that these infertile patients have had things like polycystic ovarian syndrome where they're having non-ovulatory cycles. It's really much more difficult to be certain about that. And I think nulliparity per se does not really increase the risk of endometrial cancer. It's certainly not easily identified, and we don't see it that often. Certainly, as I said, there is some evidence that long-term polycystic ovarian syndrome, where you're getting relatively unopposed estrogen because you're not having ovulatory cycles and you're not getting the luteal phase and then post-ovulatory high levels of progesterone. So theoretically, long-term polycystic ovarian syndrome, which obviously occurs more frequently in overweight people, whether it's a cause or effect is not as easily you can't be sure about that. But certainly long-term polycystic ovarian syndrome may increase your risk of endometrial hyperplasia or subsequent malignancy. And that leads me to the evaluation of the pathology. If you've got simple hyperplasia, there's no evidence that really increases your risk of endometrial cancer, but complex hyperplasia, probably about 2% of those patients will end up with endometrial cancer. If you get atypical hyperplasia, then about 20% of those patients, if they have surgery, will be actually found to have some areas of grade 1 endometrial cancer. So the interpretation by the pathologist is important, and the gynecologist certainly needs to be aware of those issues so that they can advise the patient accordingly. One of the issues that we're finding now, of course, as I said before, with morbid obesity is that we're getting a lot more young women, and I'm talking about women in their 20s and 30s who have not had children, who are very overweight and who have abnormal bleeding, have a curette, and they're found to have grade 1 endometrial cancer. Now, there are two groups of those patients that are really important. One is the ones that are mismatch repair gene proficient, so we don't think that they're Lynch syndrome patients. They will often you can often reverse those abnormal changes, even with a grade 1 endometrial cancer, with use of high-dose progestogens, both a Mirena IUD and Provera orally 200 milligrams daily. So if a 28-year-old woman who's nulliparous comes in, has abnormal bleeding, was found to have a grade 1 cancer, who's mismatch repair proficient, so we don't think that she's got Lynch syndrome, we put them on high doses of hormones, both local with Mirena and high-dose oral Provera. At least 80% of those patients will reverse those changes and get rid of the cancer. And so we can then get them on bariatric surgery or bariatric management to try and make sure that that aspect of their development of the endometrial hyperplasia and cancer can be reversed. Those patients are now encouraged very strongly to do that bariatric treatment, and in that setting we're able to perhaps preserve their fertility, and they can have children. Now, unfortunately, access to bariatric treatment is not that great, especially in the public system, as you know, so that is a constant issue for us at the moment. Now, if they're mismatch repair deficient, unfortunately, that conservative treatment actually doesn't work.
Right.
And that is a bit of a problem. And there are some clinical trials that are going to be starting in the next 12 months to examine those issues and see whether we might be able to treat them with monoclonal antibody immunotherapies for that. That's a brave new world, but that's certainly not standard practice at the moment.
So if they're proficient but young and they're treated in the way you've described, are they going to be at increased risk in 10, 20, 30 years? Are they going to be once they've had, if they've the family?
That's an incredibly good question, Luke, and it's one that we interrogate a lot. There are two things to say. One is that until you reverse the changes back to proliferative endometrium, albeit with hormone effect, if you've got a hyperplastic endometrium with atypia, that endometrium is very unlikely to be able to receive a fertilised oocyte. So IVF, no spontaneous pregnancy doesn't occur. So we are able to tell those patients, it's no good delaying this treatment to try and get pregnant because it ain't going to happen. It's a hostile environment, and it won't. The endometrium doesn't receive a fertilised conceptus. So that's the first thing I'd say. In terms of how long after, so we usually get these patients to see the reproductive medical gynecologists, IVF doctors, to try and that process so that we can accelerate their management consequent upon reversing those changes. So that's an important part of the team approach, that we get them involved in that. In terms of long-term outcomes, as you said, it's a bit of an interesting one because, as you know, morbid obesity, people can sometimes get rid of it, but it does come back pretty quickly.
Yes.
So the question that you're really asking me is, if these patients get to 40 and they've managed to have a child and they've demonstrated the biological capacity to develop an endometrial cancer in the setting of morbid obesity, should they have risk reduction in inverted commas surgery? What a very good question. I don't know the answer to it.
Yes.
But certainly it's certainly an issue, and those patients, of course, are pretty mindful, and sometimes they will elect to try and go down that path themselves, which is entirely reasonable in my opinion. We don't have enough long-term data to be able to say for sure what is appropriate, because completion surgery has occurred a lot over the years with cervical adenocarcinoma in situ. People often say, if you've got adenocarcinoma in situ of the endocervix, you've had a cone biopsy and it's okay. When you've had your babies, you should get rid of the uterus because you can't really sample the endocervix properly, and so you probably should have that surgery to take out that risk. That has been looked at and found not to actually value add very much. So it's an evidence-free zone, but can't be ignored or dismissed either.
So many controversies in medicine. I'm interested to hear what you would recommend to someone who's, say, mother or a sister, perhaps an older sister, who's had uterine carcinoma. Is there any particular kind of screening that is recommended for a first-degree relative, whether they're obese or not obese?
Yeah. So unfortunately, there is not. There is no evidence that routine ultrasounds, for instance, I mean, obviously in your area with Lynch syndrome, Luke, that's obvious.
Special.
You'd get germline mutation testing and that sort of thing. But in the absence of any demonstrable familial issue, let me repeat that. If in the absence of any demonstrable mutation, where there's a first-degree relative endometrial cancer, it's not like ovarian cancer, where we know that if you've got a first-degree relative, mother or a sister or a daughter, your risk goes up 4 times if you're under 50, if the index case is under 50, or 3 times if they're over 50. Endometrial cancer, we don't have any data on that. And it's a bit hard to know because, unfortunately, if a patient's we've only been doing reflex mismatch repair testing to exclude Lynch syndrome for about the last 7 or 8 years. So if a patient comes in and their kind of normal body habits, my mum died of endometrial cancer 15 years ago, we can almost certainly say they would not have been tested for mismatch repair. So it is the conversation which is important to have. Yes. And once again, I would say you cannot be dismissive. So you need to be cognizant of that and say to the patient, look, you might have an increased risk, but it's probably only 3 or 4 to 5%. But maybe you'd have a lesser index of suspicion, or you might have an earlier default to a hysteroscopy D and see if they had any abnormal bleeding. The use of perhaps doing 12 monthly ultrasounds in what might be an increased risk group would be highly unlikely to be valuable. Mm-hmm. And I often quote a meeting that I was involved with many years ago in London. I was asked by the UK government to do a workshop on screening for ovarian cancer, and there was a brilliant epidemiologist called Howard Cuckle who presented. I'm talking back in 1990, but the data is still the same. There are 9 WHO criteria that you need to be compliant with to have what is regarded as an adequate screening test. You need to know the natural history of the disease. Well, we don't know the natural history with endometrial cancer. We don't know how long it takes to go from atypical hyperplasia, or we know what the incidence can be, but we don't know the natural history. Do we have an adequately sensitive test? No. How often do you do the test? We don't know. So there are none of those 9 criteria that are. Is there a pre-invasive stage? Well, there is, but we can't recognise it. There's not an easy test. The only test known to medical science that is compliant with those things is a cervical screening test. You can argue about fecal occult blood, breast screening, PSA levels in prostate. None of them are actually compliant, and we don't know whether the endpoint is appropriate, because you need to pick it up in pre-invasive to be absolutely able to say for sure that you have changed the outcome.
Yes.
So it is a really important area. I think if there's a strong family history where there are multiple multiple endometrial and colon cancer, well, you're obviously going to have a lower threshold to investigate them. But yeah, unfortunately, we don't have. We've had this issue with tamoxifen usage with breast cancer. As you know, tamoxifen has been associated with a supposedly 3 to 4-fold increased risk of endometrial cancer.
Yes.
Now, I think that data is actually very wrong, because if you look at the number of patients of breast cancer in Victoria per year, it's about 3,500, of which 80% are receptor positive. A vast number of those patients are going to go on to tamoxifen. Obviously, a lot are going to go on to aromatase inhibitors too, but let's say half of them go on to tamoxifen. If your risk goes up 3 to 4-fold and your baseline risk is 1 in 70, that means you're going to go up to about 1 in 20. Well, of the sort of 600 or 700 cases a year or more in Victoria, you'd expect a fair number of those would be tamoxifen patients. Well, they're not. So there used to be a recommendation, if you're on tamoxifen, you have an annual ultrasound. It's a complete waste of time. Yes. So we've stopped doing that. We've stopped doing that now. So
like changing criteria. We often sort of seem to gain information, don't we, over time, and some of those old chestnuts do change.
Correct.
Can I ask you also, we've talked about bleeding, the link with obesity and so forth. Are there other symptoms that can be reliably taken, like pelvic discomfort? We see a lot of people in gastroenterology that come in with discomfort. Gosh, should I do any pelvic ultrasound, this lady? Is that sort of fairly unreliable as an indicator?
Correct. Yeah, it is. I mean, it begs the question about what you do with a patient who has had a few non-specific symptoms and who has an ultrasound, and they're 75 years of age, they're not on hormone therapy, and the ultrasound done to investigate that pelvic discomfort shows a thickened endometrium. Should that patient be submitted for a hysteroscopy D&C? That's quite controversial because in the absence of bleeding, the incidence of endometrial cancer is still very low, and most of them have benign polyps. But we have all had patients exactly like you've just described who have had D&C, and lo and behold, whoops, we've just found a cancer or
yes,
atypical hyperplasia. You're an extremely lucky person. So I think we do have to be very mindful of that. And if I have a patient who comes in, and I do get plenty of them referred in that exact situation, I have an open and honest conversation with the patient. I say, look, it's a bit of an evidence-free zone, but you are a bit overweight, your BMI, and we always calculate their BMI, it's 35. You're not low risk. I think perhaps you might be smart to have a curette. And, there are plenty of patients that end up with abnormal pathology. And I can tell you, I operated on one last week,
Yeah, they'd be very grateful for the intervention. I guess that's the art of medicine, isn't it? It's being clinically aware and cautious. So
Correct.
Can I just clarify, if you have unopposed HRT, estrogen therapy, we're talking about increases, if it's balanced with progesterone, is that thought to be safe if someone does have HRT? Yes, okay.
Yes, it is. So estrogen and progesterone hormone therapy is fine as long as the patient's compliant.
Yes.
And once again, if there's any evidence of abnormal bleeding, it should be appropriately investigated. But basically progestogens, whether you use continuous combined or sequential, it's harder to know for sure. I mean, things like tibolone, which obviously is an easy one. There's no progestogens. It was always said that it doesn't stimulate endometrium. Well, occasionally it does. So I don't think you can necessarily be, completely ignorant of the fact that they still could get abnormal bleeding and could get malignancy. So there are no hard rules on that one.
I really appreciate your run through endometrial cancer. That's extremely helpful.
Not at all.
Do you have a time to talk briefly about cervical carcinoma, which we're seeing, I think, less of this in clinical practice now, perhaps because of Gardasil, I'm guessing. But can you bring us up to date with
Sure.
with this situation related to cervical cancer as it is in Australia?
So just historically, Luke. Pre-1961 and mass screening, cervical cancer was the second most common cancer in women. Consequent upon the development of screening around the developed world, it became number 14 in terms of women's cancer. So it was a dramatically effective thing because, as I mentioned before, it was picking up disease before it became malignancy. And we've known about that since 1926. When people started looking at scraping the cervix with a wooden spatula. Unfortunately, over the past 60 years, 90% of women who got cervical cancer were women who were unscreened, so you could argue it was their fault, but 10% were women who dutifully attended but were let down by the system because of this concept of false negative cervical screening tests, especially in the old system of exfoliative cytology. In the 1980s, in the UK, John Tidy wrote a brilliant paper on HPV and the causation of nearly all cervical pre-malignant and malignant disease. And as you know, there are 120 types of HPV, but probably only 20 can give you malignancy, the so-called oncogenic subtypes. So on December the 1st, 2017, we started our cervical screening program with HPV subtyping rather than exfoliative cytology. So we're now getting a vast number of women who come in, whether they've been inoculated with Gardasil or Gardasil 9, the original Gardasil or Gardasil 9. We still get a large number of patients who come in with positive HPV subtyping and they're sent off for a colposcopy. The overall incidence of cervical cancer has dropped. There's no question about that. But I can tell you, sitting here at Monash Medical Centre, especially in the public health system, most of the patients that we see with cervical cancer now are actually locally advanced, so they're inoperable and they have to have chemoradiation rather than surgery. And that is because these are, largely speaking, patients who were born overseas and who probably didn't get Gardasil and were never educated about cervical screening. So there's no doubt that there has been a dramatic change in the number of women who come in with early-stage cervical cancer who are eligible to have or appropriately managed with primary surgery. So it's definitely shifted. I was alarmed when I heard on the radio people were saying, "Oh, cervical cancer is going to disappear, because of the vaccine and this new test." Wrong. We are still seeing quite a lot of locally advanced cancer of the cervix, and it's not going to go away in a hurry because there are large groups of our population, especially women from Muslim countries, unfortunately, where they are prevented from having screening, and their culture, unfortunately, seems to dissuade them from having any of that type of management. And that's just the reality. It's not a commentary about that group of people, but the number of patients like that who we see now with advanced cervical cancer is pretty devastating, and some of them are young women too.
Well, it's important for primary practitioners to be aware of that, I guess, particularly those new immigrants.
Correct.
Can you tell me, well, two things. First of all, should Gardasil be should we have a booster at like 10 years? Is that controversial, or is that recommended at the moment?
No, there's a couple of things to say. First of all, if women have had the original Gardasil, which only covered 4 subtypes, so 6 and 11, 16 and 18, if they come in now, I actually advise them that they can benefit from having Gardasil 9, which has got another 5 subtypes covered. So I do recommend that they try and do that.
Yes.
Secondly, there's some evidence that will be helpful. The other thing is that it is fair to say that the so-called geometric mean titer, the marker of immunological response, over the age of 48 probably means that there's no value in women having vaccination over the age of 48, but certainly they should have it up to the age of 48. In terms of how we increase that, I don't know for sure. Obviously, most women are happily getting it at school, I think at about 14 years of age or something.
Yeah. Is it 100% effective?
No, the short answer is no, it's not. And I don't know why that is, but it's pretty good, but it's not 100%.
I guess like all vaccines, you don't always get an immune response. But I guess for women, they should know that if they have symptoms, regardless of if they've had Gardasil, it doesn't completely
correct.
Them. That's been very, very helpful, Thomas. I want to thank you very much for your expertise.
Delighted.
I've learned a lot from discussing this with you. It's been extremely valuable. Can I ask you one last thing? The best advice that's been given to you as a doctor?
Best advice. Well, I can tell you, my old colleague Arthur Day, who died about 4 years ago, used to say the price of fame is eternal vigilance. I think that's right. So you listen to the patients and don't be lazy. So in my own practice, I always make sure I do a smear test on pretty well anyone that moves. Not so much if they've had one recently, but I do think that Arthur's commentary was incredibly helpful for and obviously listen to the patients.
They have a lot to teach us, don't they? Thank you so much, Thomas. Really appreciate it.
Not at all, Luke. No trouble, and we'll talk again soon.
Thank you. Thank you for joining me in this conversation with Professor Thomas Joblin. I found the discussion on endometrial and cervical cancer very interesting, and I hope you were able to learn as much as I have been able to and take away some of the gems from his discussion. During the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Tom will be returning to talk about ovarian cancer. I do hope you can join us in that episode. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and may be emailed to manager@gihealth.com.au.